on to workplace violence. We're gonna do an activity in that textbook that I showed you. So this is in the learning activities of chapter 15 of that free textbook online. And it's a therapeutic communication with domestic violence. So we're just gonna work on it together, but if you wanna follow along, you're welcome to go to the textbook. I think this is really cool because it has some like auditory stuff. It has a patient in moulage that you can actually see that's gonna talk to you. So I like it. All right, so family and domestic violence, including child abuse, intimate partner abuse, and elder abuse, is a common problem in the United States. Family and domestic health violence are estimated to affect 10 million people in the United States every year. It's a national public health problem, and virtually all healthcare professionals will at some point evaluate or treat a patient who is a victim of some form of domestic or family violence. According to the CDC, 1 in 4 women and 1 in 7 men will experience physical violence by their intimate partner at some point in their lifetimes. Those statistics are staggering. All right, so we have Allison Underwood, who is a 32-year-old stay-at-home mom of 2 kids in a small rural community. She has presented to the emergency department 5 times in the past year with pattern bruising typical of intimate partner violence. Let's listen to our handout report.
Allison B. Underwood, 32-year housewife with 2 children. She presents to the ER with pattern bruising on her arms and a laceration on her forehead caused by alleged domestic abuse. She is married to the police chief in town, which makes this a sensitive issue. Ms. Underwood has been to the ER 5 times in the past year for similar problems. I know she wants to leave, but we are waiting on some paperwork. Could you please go and check on her?
All right, so what are your concerns?
She's married to the chief of police.
Yep, that's definitely a concern. What's your priority concern as you go in her room? What are you, like, what's your nursing priority? Okay.
Getting him out of the room.
Okay. I don't think he's in the room. Yeah.
We need to make sure she's physiologically safe.
Yes, we do. Very good. Right, so we gotta check the injuries, all right? And we have to make sure that she remains safe as well. So we would let other people know that this is happening because we need security to be aware if he shows up, right? And we don't want him to just be let back.
I really need to get back home. My husband calls me during the day to check up on me. He likes to know my schedule. He will find out if I am here.
All right, so what in her presentation is concerning
I really need to get...
for abuse?
Control. He's controlling her schedule.
Just physically looking at her.
Of her eyes.
Yeah, these are not typical injury patterns that we would see unless this was someone intentionally harming her, right? She's got a bruise over her eye, she's got a split lip, she's got a bruise on her forehead. That's not a typical injury pattern from just falling. All right, which of the following statements is the best response to her at this time? You seem concerned about your husband finding you here. Help me understand your concern. Why are you afraid that your husband will find out you're here? Don't worry, the paperwork is almost done. You'll be able to leave soon. You shouldn't have to worry about being here. Why would your husband be mad about that?
The first one.
Okay, which ones can we automatically mark out?
The 2 with why
The
statements.
2 with whys, that's exactly right. Therapeutic communication is never gonna be a why question. All right, why not this one?
It's
Don't worry,
dismissive.
it's very dismissive, yeah. All right, good job.
It's my fault this happened. I wasn't doing my job as a wife. It won't happen again.
Okay, and we often see victims blame themselves. All right, so what are we gonna say to her at this point? This isn't your fault, this is your husband's fault. I'm sure you're doing a great job as a wife, but it will happen again. Last week I had a patient tell me exactly what you were telling me, but yesterday she came back beat up again. Or I understand you feel this won't happen again, but you've been here before.
The last one.
Okay, the last one, anyone have a different response? Okay.
I don't know what to do. I feel trapped, but I have nowhere else to go. I don't think I can leave him.
Which of the following statements is the most therapeutic response to Allison now? You should leave that man and move far away from this town. Why don't you think you can leave him? There are options and resources available to you. You can come stay with me for a few days. I want you to be safe.
The third one.
The third one, why not one?
You never suggested one.
Judgmental and it's advising, okay? Why not two?
It's a wise statement.
Starts with why, yes. All right, and why not four?
It's inappropriate.
That is an inappropriate professional boundary, okay? So we need to make sure we are maintaining professional boundaries and not inviting our patients to come stay at our home.
Especially one that the police chief.
You don't get it. He's the police chief. He finds out everything I do. I need to leave. Please.
All right, what are we gonna tell her now? Don't worry, the social worker will take care of everything. I do understand, a friend of mine went through the same situation. She left her husband and moved to another state and everything worked out okay. He won't find out anything that happens here because of HIPAA. I know you are worried. If we help you find a safe woman and children's shelter where you can't be found by your husband, would you consider that option?
Last one,
Okay, why not number 3?
because it's not true.
You don't know what else.
You can't guarantee it.
It should be true. He's not a medical professional.
It was a small
It's a
town.
false hope.
It's a small town. It's also dismissive, and it does not address what she's concerned about directly. It's just like, hey, don't worry about it. It's very dismissive. All right, so that's why this is the best option. All right, conclusion, she is interested in learning more about potential shelters. She thanks you for your care and assistance. You contact the social worker to share more information before she leaves the hospital. Okay, any questions about that? All right. Therapeutic communication is heavily tested on standardized tests. All right, so we talk a lot about this stuff, but they will often just throw up therapeutic communication questions. So any chance you can get to practice therapeutic communication with stuff like this, I recommend taking it. All right. Okay, let's talk about workplace violence. What is workplace violence? It's undesired consequence when working with people in stressful situations. Do we have stressful situations in healthcare?
Absolutely.
Yeah, how often?
Every day.
Like literally all the time, right? It's the nature of the job, okay? So this includes threats, harassment, intimidation, verbal abuse, physical assaults, and we can even see homicide. Here are some statistics specific to healthcare. 41% of registered nurses are victims of bullying, incivility, or other acts of workplace violence. 27% of nurses have witnessed workplace violence. 10% of nurses say their organization addressed the issue of violence very well. That's terrible. Right? 63% of nurses say their organization didn't address the issue of violence well. You guys are about to be looking for employment as nurses. This might be something that you want to ask in that interview. Hey, what are your precautions against workplace violence? How do we prevent that? What do you do if it happens? How am I sure that I'm going to be safe? All right, here are some specific instances that have happened. In February of 2025, a man zip-tied workers together and shot a nurse, doctor, custodian, and killed a police officer. In June 24th, 2021, a nurse at EAMC was stabbed in the chest by a patient she was caring for or told her you are going to die anyway. That's right down the road.
Did she die?
She did not die. April 4th, 2019, a nurse attempting to help a coworker was attacked and she died 5 days later. January 16th, 2018, a nurse received a dislocated jaw from a patient's punch. In March of 2008, a gunman opened fire at Doctors Hospital in Columbus, killing 3. So this is real and it's here. It's everywhere. This is not just a remote thought. This is something that you're gonna have to be aware of and deal with no matter where you are. All right, workplace violence warning signs. It typically occurs during the tension mounting phase, meaning we are getting upset about something. Person may have confrontational behavior, angry demeanor, they're gonna be loud and aggressive speech. They may be tense posturing, meaning they're gripping arm rails tightly, they're clenching their fists, they're pacing. They're frequently changing body position or pacing, and that's due to the increase in anxiety that they're feeling. So if you remember back to your anxiety lecture, there are 4 levels of anxiety, and once we get to that high one, that 4th one, then we are at risk of harm to others. So a lot of times this is where these people find themselves. They have aggressive acts, pounding walls, throwing objects, or hitting oneself. And there is an acronym, STAMP, that is warning signs of violence. The more of these the patient has, the higher the risk for violence occurring. So staring at intense eye contact, like this. Tone and volume of voice. If they're talking calm, then that's all right. But if I'm yelling at you like this and I need to get your attention, that's a warning sign. Anxiety, I just talked about the levels of anxiety. Your anxiety may be a little high right now. Sorry about the yelling. Mumbling to themselves, so just pacing and mumbling. You've probably seen this on the unit. Oh, I don't know what's going on. I'm so pissed off. Right? They're pacing and they're mumbling. All right, so what do we do about it? We try to de-escalate, but if we fear that a patient is violent or they are about to become violent, we are going to call for backup. You're not just gonna go up to this person who has all of these stamp things happening and try to calm them down by yourself. So, number 1 is make sure you and others around you are safe. All right, so de-escalation, what is it? Number 1, decide if a patient is appropriate for verbal de-escalation. They might not be, right? If they have a gun, it's not time to verbally de-escalate. It's time to run, hide, fight. Clues include a patient which is responsive. If they will engage in a conversation with you, if they will respond to you, then we can de-escalate with them. If they won't, then this is probably not gonna go well. All right, ensure safety, ensure adequate backup. We're calling for backup once we see those signs start to occur. All right, where's my red X?
I think that's last.
Okay. Form a relationship. Introduce yourself by name and title. Ask what they like to be called. Ask, will you allow us to help? Right? We want to give the patient as much control as possible without giving them all of the control, right? We are maintaining authority in the situation, but we want to allow the patient to have as much control as is safe. Utilize interest. Identify the patient's wants and feelings. Agree to as much as possible, either in truth, principle, odds, or odds to disagree. All right, so what does that mean? That means we don't want to just tell our patient, no, 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 absolutely not. If we can give a little, we're going to give a little, and it will help them calm down and we can avoid a violent situation. Set limits. Speak matter-of-factly about consequences for bad behavior. We have to be careful about this because remember, we cannot threaten patients. So it can't be, if you don't calm down and sit down, I'm going to throw you in restraints. That's not appropriate. Offer choices for behavior, even if it's between oral and IV medications or IM medications. If we're looking at the mental health unit, who usually doesn't have IVs. Use repetition as needed until you are heard. And then enforce or evaluate. If the aggression escalates and violence seems imminent, withdraw and mobilize help. We already got help before this stage though. Once the situation is diffused by either verbal de-escalation or medication, we want to debrief staff and or the patient. Debriefing is huge in mental health. We debrief after everything, okay? And don't forget that if this is happening on the mental health unit, that you have other patients in that milieu that you may need to debrief with. So if you have a patient who's getting upset on the unit and they're becoming aggressive or they may be violent, then you also need to debrief with those patients that may have witnessed it, or you're gonna be giving out a lot more injections and you may be putting more patients in restraints. So make sure everyone else is okay. Right, what we're not gonna do is antagonize. Hey, this is ridiculous, why don't you calm down? Right, we're not gonna argue with the patient. That's not helpful, that's never the answer. You're not gonna get close to the patient because if you need to leave, you wanna be able to do so quickly. You're also not gonna let the patient get between you and the door. Okay, so if I have a patient who's upset, I'm not gonna be down here. I'm gonna be up there, or I'm gonna be right there, so that if I need to leave quickly, I can. All right, you're not gonna have things on you that can be used as a weapon. This doesn't go on the mental health unit, okay? Or in any patient's room that I think could be dangerous. Or in any situation where I think someone could potentially be violent. Don't wear your stethoscope around your neck. That gives someone something to hold on to and strangle you with. So be aware of things that you have on your person. Also be aware of things that are in the room. There are tons of things in your med-surg room that your patients can use to hurt you or someone else. Right? We limit those on the mental health unit, but on med-surg floors, you got IV poles. You got a bed that can move. You've got cords that can wrap around. You've got a sharp box that they could potentially pull things out of. Right? There's lots of things that can be used as weapons on a med-surg floor. Don't threaten your patients, that's illegal. Don't condescend or interrupt. We want to allow them to talk as long as it's appropriate, right? We're not gonna criticize them. We're not gonna respond defensively. That's ridiculous. I don't know why you're saying that. You need to stop. It's not appropriate. And we're not gonna lie, because then your patient is going to be, they might be all right now, but when they figure out you're lying, you're gonna have another episode on your hands. Okay, so we are always truthful. Right, questions about this before we move on? Okay. All right, restraint review. When do we use restraints?
And everything else is fair.
When everything else has failed. This is correct. All right, so you have to try something else. Now, sometimes that something else looks like me telling you to stop, you don't stop, so you go on restraints. But the first day of clinical this semester, we had a patient pick up a security guard, body slam him on the floor, and he did not go in restraints. And that was a clinically appropriate decision. So let's talk through why that was clinically appropriate. That patient was hallucinating and paranoid. And when we told him to stop and go to his room, he stopped and went to his room. All right, so he didn't meet criteria for physical restraints because physical restraints are never punitive. They are always there to keep your patient and others safe. But we don't put someone in restraints just because they did a behavior. All right, that's punitive and that's not what we do. Now, what do you think we did do to that patient? We didn't put him in restraints, but what do you think we did?
Medications.
Medications. What kind of medications do we use for our aggressive patients? Haldol, which is what kind of medicine?
A first generation
It's a
antipsychotic.
first generation antipsychotic. Haloperidol is the generic name of that. All right, why does an antipsychotic help this patient who is aggressive? Well, this one specifically was having hallucinations. But what behavior am I targeting? Yeah, it's indicated for agitation. So it is a great antipsychotic, works well on psychotic behaviors or features, but it also can be used for agitation. Okay, so you very well may give it to someone who does not have schizophrenia or is not psychotic. All right, what are my big side effects for first generation antipsychotics? There's 3 kinds. Extrapyramidal symptoms, and what are they? There's 4 of those.
Dyskinesia. Is dyskinesia?
Tardive dyskinesia, yep. That's a negative symptom. So, and we could see that because my first generation antipsychotics don't treat my negative symptoms.
They have like Parkinson's.
Yeah, like Parkinson's. So Parkinsonism, and that's because of the way it affects dopamine. Schizophrenia and Parkinson's are actually inversely related when we look at dopamine. So when we start messing with dopamine because of schizophrenia, we can actually cause something that looks like Parkinson's. So Parkinsonism is another one. What's that first one that can happen that has muscle rigidity and contractions and I can't move like this? Because they're all movement disorders. So what one can look like this? Acute dystonia. We actually had a patient have that reaction yesterday. And then my fourth one is akathisia. That's the ants in the pants where your patient can't stop moving. How do we treat extrapyramidal symptoms?
Benzotropine.
Benztropine, yes. And I can also use what medicine? Say it louder. Diphenhydramine, yeah, Benadryl. Okay, so one of those, and it's physician's preference, whatever one they wanna use. I can use that for all of them, except for tardive dyskinesia. It's not gonna get that one better. There actually is a medicine now that treats tardive dyskinesia. It's a newer medicine. You won't be tested on it for that reason, but it is kinda neat that we've got this thing that hasn't been able to be treated for years and years and years, and now there's a medicine that treats it. If my patient has akathisia, I have some other treatments I can use. I can use a benzo, which will help calm them down. I can also use a beta blocker, which will help calm them down. All right, so that covers extrapyramidal symptoms. What are my other two big side effects for first generation antipsychotics?
I know the treatment for one of them, but I can't think of the name of the thing that happens.
The adrenal related? Adrenal related?
It's not. Well, it's anticholinergic. So we have anticholinergic effects, and then they can also be photosensitive. So when you're thinking about what to teach your patients who have been on first generation antipsychotics, that's what we're going to teach. We're specifically going to be concerned about that acute dystonia if we're given this for agitation, especially if we have to give multiple doses. So remember, acute dystonia is that one that can happen within a couple of hours to a couple of days of either increasing or starting a dose of a first generation antipsychotic. So we need to make sure we monitor for that one in that acute phase. And also neuroleptic malignant syndrome. What is that?
That's the one I was thinking of. It's in the treatment dantrolene, right?
Yeah.
It's the elevated temperature, I think they can get.
Yeah, they can have an elevated temperature, so vital sign lability. Vital signs are a little bit everywhere, right? And that's the thing we're gonna monitor for it. Ooh, why did it do that? From this slide. Why is it not? Okay, that's fine, whatever. So vital sign monitoring. All right, what other medication can I use for my patient who is acutely aggressive? Ativan, which is what kind of medicine?
Seizure med, isn't it?
What? Technically it can, it's a benzo, yes, so we can use it for acute seizures. It's a benzodiazepine, lorazepam is the generic for Ativan. What is Ativan gonna do for this acutely aggressive patient? It's gonna calm them down, yeah, sedate. So we're looking at chemical restraint here, right? We're trying to give them medicine that's going to calm them down. All right, so my patient that was physically aggressive and went to his room did get PRN medication for acute agitation because that was warranted, but restraints were not. Oh, that's where we are with restraints. Okay, so if I put my patient in restraints, what has to happen?
You have to
Has to be
assess.
there.
Well, the doctor has to order it.
Doctor has to order it, yep. And can I have a PRN order? This patient's been aggressive several times. I know that I might need restraints now. There's not a lot of nevers in nursing school. This is a never. You can never have a PRN order for restraints, and that goes for behavioral and medical restraints.
They have to be assessed every 15 minutes?
That's correct. They have to be assessed every 15 minutes. And what kind of assessments are we doing every 15 minutes?
Neuro checks and skin checks, and
Okay.
then their pulses to see if it's too top.
Okay, I like it.
And we're assessing the need for the restraint,
Yes, we are. And how do we assess that?
their level of agitation or their behavior.
Right, their behavior. That is your, hey, they still meet criteria to be in restraints documentation. So make sure you're assessing behavior. Should you document that someone is asleep in behavioral restraints? No, why?
Because
If they're asleep, they don't need the restraint.
If they're asleep, they don't need restraints. And also, they're probably asleep because you gave them chemical sedation and now you've chemically sedated them and physically restrained them, and that's not safe. So, when do we take them out of restraints?
Every 2 hours? You have to,
When they don't need them anymore, yeah. So, criteria for better behavior, right? When we know that they're not gonna be violent. So if they're still yelling at you, threatening to kill you, it's not time for them to come out. But if they're calm, they're responding to redirection, they're listening to you, they're able to converse with you, those are pretty good signs that they're probably ready to come out of restraints. When you let them out of restraints, probably a good idea to have security around, just in case they decide that that's the time they wanna act up again. Okay, but yeah, we let them out as soon as they can come out. Alright, so we talked about what we're assessing every 15 minutes. Every 1 to 2 hours, we also need to make sure we're assessing elimination, hydration, nutrition. And then when we put them in restraints, we need to do a full head-to-toe assessment with vital signs. Alright, because I just told you that if they're following directions, they aren't gonna meet criteria for restraints. So they didn't just walk down to your restraint bed, lay down, and let you put restraints on them. They did, they probably could have just walked to their room, got some medicine, and then took a nap, right? So because of that, we have a risk of injury to both our patient and our staff when someone goes in restraints. So they need a full head-to-toe assessment. Good facility policy is that that assessment is done by someone who is not involved in restraints. So like at East Alabama, if we put an adult in restraints, we're probably gonna pull someone from the long-term adolescent side that hasn't seen that patient that day to come do a full head-to-toe assessment, just to keep objective eyes on your patient, because we know that adrenaline is high when we're involved in a physical altercation with the patient. We wanna make sure the patient's safe and we haven't overlooked something. Right. Questions about any of that? Alright, what's the difference in behavioral and medical restraints? Different question. Can a soft wrist restraint be a behavioral restraint?
Probably not, that's more for like pulling out tubes and.
It is, but it can be. So it's the reason you put someone in restraints, not what the restraint actually is, that determines if it's medical or behavioral. So if you have soft wrist restraints on your 89-year-old male up on the floor who is delirious but trying to punch you, then that's a behavioral restraint, because he's in it because he's trying to punch you. Now, if he's in it because he's pulling his lines out, that's a medical restraint. So it's the reason you put the restraints on, not the restraints you put on, that determine if it's medical or behavioral. Behavioral restraints also require a line of sight when they're in them. Do medical restraints? No. How often do you chart on medical restraints? Every 2 hours. Okay. Debrief. We kind of talked about that already, but once your patient comes out of restraints, we do want to make sure to debrief with them. If they're sleepy, they're going to their room to take a nap, it might not be time to do a full debrief with them. We might just say, hey, we gave you some medicine, why don't you go take a rest? We'll talk about it in a little bit, right? Make sure they do understand behavior limitations, can't be aggressive on the unit. That's not safe for you, it's not safe for me, it's not safe for other patients, so we need to make sure that we're calm. If you need anything, please let me know. But at some point, we need to circle back to talking about, hey, what led up to this? What got you upset? What can we do better in the future to prevent you from going in restraints and prevent us from having, a violent episode on the unit? So make sure you debrief, not just with the patient, but also with your staff and with the other patients on the unit. If you've got paranoid, anxious patients who just witnessed a violent episode on the unit, you're gonna have some other PRN medications you probably need to give out, and you need to talk to them and make sure that they are psychologically safe. All right, questions? Okay. Let's do some practice questions. All right, I will put these up after lecture today. You will have them. Okay, these may actually During a client who's been displaying aggressive behaviors, the nurse observes that the behavior displayed by the client is escalating. Which nursing intervention is the most helpful to the client at this time? So let's all that explain. All right, who likes one? No, don't confine them. What's that gonna do?
Make it worse.
Make it worse. It's gonna make them more anxious, it's gonna make them more agitated. Let's not do that. All right, what about 2? Yes, let's acknowledge the client's behavior. What about 3? Yes, let's decrease external stimuli. That's usually a good option for anyone who is upset or escalating. All right, 4, do we like that one? Absolutely. I don't want to be close to anybody, so especially someone who's escalating. Let's keep a good distance from them. All right, what about 5? No, you maintain authority. We will give them as much control as we can, but you maintain authority of the situation. All right, a nurse attends an educational session on family violence. Which statement by the nurse indicates a need for further teaching? Four. Anyone like anything different? I like 4 too. Remember that it's not one way that someone looks, it's not one socioeconomic class, it's not one race, it's not one ethnicity. This happens across the board, so we don't want to stereotype and miss someone who may be in an abusive situation. When would the nurse determine that it would be safe to remove the restraints from a client who demonstrated violent behavior? Four. Anyone like anything different? 4 is correct. Why? Right, this is clear evidence that they are calming down, they're not aggressive anymore, so that's why it's the best choice. Now, it doesn't mean that every time we put someone in restraints, we have to have no aggressive behavior for an hour. That's just the best answer that is up here. 10-year-old referred for evaluation after drawing sexually explicit scenes, says to the psychiatric nurse, I just felt like it. Which response by the nurse is focused on assessing for abuse-related symptoms? Anyone like anything other than 4? Why is it not 3? 4 is correct.
It's accusatory, no.
No, it doesn't.
It's not direct.
Yeah.
It's not direct, right? We're talking about other people that you don't know anything about. So remember, we are always truthful, okay? I'm concerned about you. Are you now, or have you ever been abused? Also ask very direct questions. When planning care of a client with a history of violent behavior toward others, the nurse would include which intervention? Select all of them. All right, do we like 1?
No.
No. If someone has a history of violent behavior, I don't want to provide complete privacy because I may need assistance. All right, 2. Do we like that one?
Mm-hmm.
Yes, they need to be closely monitored, absolutely. 3, do I like that one?
No.
No, we don't need to avoid eye contact. Don't stare intently, but you can have eye contact. 4, do we like that one?
Yes.
Yes.
Yes, absolutely. All right, 5, do we like that one?
No.
No, right? Any questions about that one? This is fine. All right, sexual assault. So, terms are important here. Sexual assault is a more broad term. When we talk about rape, legal definition requires penetration for rape. But sexual assault can be penetration, it can be fondling, it can be any inappropriate touching. It can be forcing someone to look at something that is sexually explicit against their will. So it encompasses a lot of other things. All right, it is non-consensual, and that's the big thing. The victim usually knows the perpetrator. common myths related to sexual assault. What are some things that are myths related to sexual assault?
It only happens to girls.
It only happens to girls. Well, if you wouldn't wear those clothes, it wouldn't be an issue, right? That's a myth. It doesn't matter what you're wearing. Well, if you weren't doing this activity, then it wouldn't have happened. Okay, so we like to victim blame and say that if someone wasn't doing something, that would not have happened, but that's not the case. Okay, it's never the victim's fault. Women and children are at the highest risk, but they are not the only ones who are victims. All right, nursing intervention for sexual assault and rape. We want to make sure we assess victims for injuries ASAP. We're remembering physiological needs and safety here, okay? We want to maintain privacy. Do we have to report sexual assault?
As long as they're competent.
Right, so it falls under the rules of abuse. So unless it is a child or elderly person or a protected adult, we are not required to report it. We'll talk about SANE, sexual assault nurse examiners, in a bit. But our victim gets total control here, right? We do want to make sure we assess for injuries, we take pictures, we document very objectively. We're not going to infer anything. We're going to document exactly what we see, exactly what our patient says. We do want to make sure that our patient does not shower, does not brush their teeth, does not change clothes, because those are all going to be used in evidence collection. All right, and the SANE or the sexual assault nurse examiner, if you have access to one, is the one who is going to do that rape exam and collect that evidence. And the victim does not have to file charges in order to have that done. Or they can get the evidence collected and then it can sit somewhere until they decide if they want to file charges or not. They can also have some of it collected and not others collected. So they get to determine what's done and how much is done. It's all up to the victim. We do want to make sure that we are given really good explanations, that we are providing safety by not leaving that person alone. So you're not just gonna leave them in a room and walk out. They need to have someone with them at all times. We wanna make sure we obtain written consent before we do any evidence collection. We wanna make sure we provide medications. That can include medications for possible STIs, emergency contraceptives, and then anything else that she may need. So if she's in pain because she's hurting, then we would give pain medicine, right? So anything else she may need. We would refer her to crisis intervention groups, and there is something called Rape Counselors of East Alabama in this area that we can call, and will come and sit with the patient who has been the victim of rape, and they will kind of walk her through this. They are victim advocates. They can provide really good education. They usually come with a change of clothes. And the med clinic on Auburn University's campus actually has a kind of rape exam room, and it has a shower in it. So once the exam has been done, they can go and shower, and they have clothes in there so they can change clothes, and it was all funded by their SGA, so it's really kind of cool. At Auburn. Auburn University Med Clinic is under East Alabama's umbrella, but it's housed on Auburn's campus. All right, questions so far? Okay, so when I'm looking at priorities, what are my priorities here?
Making sure they don't shower or change clothes.
Yeah, and safety. So assess for injuries, make sure that your patient can protect their airway, that they're not bleeding out, that we don't have anything we immediately need to attend to. Okay. Then we need to do some education, assess for injuries, and go about collecting evidence. If they agree to it, she can say absolutely not. And then we allow her to shower, do whatever she needs to do, treat her as she will allow us. But she has, or I'm saying she, it's not always a she. There's that stereotypical stuff, right? This can be a male, and it can be a kiddo, so. Okay. what does a SANE nurse do? So a SANE nurse is someone who comes in and does evidence collection, kind of takes care of this patient from start to finish once we figure out that they are a victim of rape. So documents history and details of assault and injuries. They do testing and or prophylaxis for STIs and pregnancy. They will conduct the physical exam and medical treatment per the physician. They can appear in court, and they can do education to the community. They provide evidence collection guided by the account of assault. And they link the patient to support services with follow-up planning and care. So any nurse, once you are a registered nurse, can go through training to be a sexual assault nurse examiner. And there's a team of them at East Alabama, all of the nurses at the med clinic, about a year ago at least, I don't know if they've hired anyone else, were trained in sexual assault nurse examiner so that there's always someone there that can do that. So it's really interesting and it's very good for victim advocacy. There's lots of things that have to happen for evidence to actually be able to be submitted to court. So it's really nice if you have a SANE nurse available that can do that to make sure that you don't mess up the chain of command or the chain of evidence. Well, I don't remember what it's called. But if you let it out of your side or if you don't do something just so, then they can't use it for court. Okay, questions?
Chain of custody.
That's it, chain of custody. All right, same exam again. They do evidence collection. They don't have to report to police unless they are a protected class. This is up to the victim. They only do the steps that the victim chooses. They do STI and pregnancy prevention. If they choose it, is free. This is not something that the victim is gonna have to pay for. And then again, here in this area, we have rape counselors in East Alabama, which are local victim advocates. Right, rape trauma syndrome. This is something we can see after rape occurs. So this is a form of post-traumatic stress disorder. So we have to be concerned about triggers. What do we know about post-traumatic stress disorder?
They can show up in a long time from now.
Right, it can show up a long time from now. Who do we typically associate PTSD with? What'd you say?
Military.
Military, yeah. So we think about it a lot when we think about our veterans. But this can happen with anyone who has been through a traumatic event. And so triggers are an issue. So often if we have military patients who have PTSD, they may be triggered by loud noises or something that they associate with being in a war zone. And they have no control over kind of what happens once that trigger is there. So signs and symptoms can include sleep disturbances, flashbacks. What are flashbacks?
Reliving it.
Reliving it. So we see a trigger and then we relive whatever that experience was. We can have decreased appetite, have low self-esteem. Psychosomatic complaints, what is that? It's like a physical complaint where we don't really have a reason for it. So my stomach hurts and I don't know why. It's not because I have a GI issue. It's not because I'm sick. It's a psychosomatic complaint. Or I have a headache. And it's really related to whatever psychological thing is going on rather than a physical reason. Inability to maintain relationships, which is true for most of our mental illnesses. There can be fear. This is by definition an anxiety disorder. And then we can have phobias because we're trying to prevent the trigger or reliving those flashbacks or having those symptoms that are distressing. How do we treat PTSD?
Therapy.
Therapy, yes, and there are some specific therapies we can use. Are there medicines we can use?
Usually yes.
Yeah, SSRIs, those antidepressants that can also treat anxiety are really good options. So SSRIs, SNRIs. Right, questions? Alright, so in a nutshell, my patient comes in and is reporting that they have been raped. What do I do?
Assess for injuries.
Assess for injuries,
Safety.
Safe environment.
maintain safety,
Stay with the client.
stay with them, get consent, right? access the same nurse, yes. If we don't have a same nurse, we're gonna make sure that we document thoroughly, take pictures, as long as our patient consents to it. What do we not want them to do? Shower, brush their teeth, change their clothes, yes. And then once they're in the hospital, we've kind of figured out what's going on, we need to make sure we maintain safety and confidentiality. We're not gonna announce, hey, so-and-so was in room 3. We're gonna make sure we're very quiet about where that patient is. We're not gonna report it, we're not gonna let anyone back to see them without their consent. Would it be appropriate to contact a friend or a family member?
If they ask you to.
Yes, at their consent, absolutely. All right, let's do some questions on that. And then we can take a little, like, 5-minute break. I think we will get out of here early today. It's my goal. I have clinical at 6:45.
We love leaving early.
I got what you need to see, so. All right, a client was raped a few weeks ago, but still feels as if it just happened to me. Which response would the nurse make to the client? Anyone like anything else? Nope, we like 3? Okay, I like 3 too, that's right. Why is it not 1?
It's
Because
good.
you don't, she didn't help me to advise you to get over it.
Right, that's not helpful, that's dismissive. All right, why is it not 2? That's victim blaming, yeah. That's assuming that it was her fault she was raped or that she could have done something. Again, does it say it was a her? Y'all stop me when I do that. That it was their fault that it happened, or that they could have done something to her benefit. All right, why is it not 4? It's dismissive, yeah. Hey, that's not a big deal, why are you so worried about that, is basically what they're saying. Patient presents to the emergency department stating they were sexually assaulted. What is the nurse's priority action?
C.
C, yeah. Anyone like anything else? Excellent. When caring for a sexual assault survivor, which statement by the nurse demonstrates therapeutic communication?
C.
C, anyone like anything else? No, always making sure that your client knows they are safe is a good option for therapeutic communication. A sexual assault survivor declines to report the incident to law enforcement. Which nursing response is the most appropriate?
B.
B, okay, anyone like anything else? I like B too, that's your choice, we can still provide care and collect evidence, absolutely. Which action by the nurse would violate evidence preservation procedures? C, yeah, we can't let them brush their teeth if they want to collect evidence. The nurse is preparing to discharge a patient after sexual assault evaluation. Which discharge plan is the most appropriate? Okay, anyone like anything besides A? Okay, I like A too. Which nursing action best reflects trauma-informed care?
A.
A, explaining each step before touching the patient, absolutely. Minimizing questions is never the answer. Encouraging detailed recall of the event could re-traumatize, that's a no. Collecting evidence as quickly as possible is not gonna allow you time to explain what's going on to the patient, so that's not appropriate. All right, any questions? Let's take a 5-minute break. Wait, let me make sure, oh, no, that's one more. The nurse is documenting the patient's description of a sexual assault. Which documentation is the most accurate? C, has quotes, right? Patient reports being sexually assaulted by a known individual is not specific enough. Patient states she was raped, I need more information. Patient reports he forced me to have sex after hitting me. That's not inferring anything, that's using quotes from your patient, and it's very specific. Patient alleges that she was assaulted. C is the best answer there.